Um, cool. So that is all on housekeeping stuff. So totally optional, but I just thought it'd be useful to gather some resources together. So let's start with a couple of cases and then we'll get into the content. So these are some real cases that helped inspire this talk. So this is a case from my clinic. So our patient is a 40-year-old man with multiply relapsed B-cell lymphoma. He's had CAR-T twice. And now he's in a place where the oncologists are telling him that his prognosis is dire and that he can probably expect to live on the order of months. This family has a 3-year-old daughter. They don't have any specific questions for us, but they are really worried about her life without her dad and how she's going to adjust. Then the second case that came to mind, this was a case at Harborview that was managed by Kira, but this is a case of a 55-year-old previously healthy male who had a severe anoxic brain injury after a motor vehicle accident. And the family is planning on compassionate extubation. He has 3 kids. I think they were about 6, 8, and 11. And the mother wants to bring the kids in to help them understand what's going on. And their question was, how do we get them prepared? What should we tell them before they walk into the room? So these are, oh gosh, I'm dropping in the chat the link to the doc. So these are cases that come up all the time that are that inspire this talk. Long story short. Okay. So when I'm thinking about, even I as a non-parent, I know that these are difficult conversations to have, but I think it's really helpful to think about, what are the specific elements of this conversation for parents that they make it really challenging? What are their specific worries? So I was wondering if folks are interested, if you could take a minute or two and drop into the chat in your experience working with patients who are parents, what are the specific worries that have been expressed, or what are the things that might present as barriers to them initiating conversations with their kids? So I'll just wait for a minute or so and then we can see what people think. Yeah, I think that these are good examples. So they're worried about providing them with the right information, developmentally appropriate information. They're worried about being scared or scaring the kids. Wanting to protect their child, protect them from trauma is a really big one. Not wanting to traumatize. Yeah. Some of the other things that also, or not knowing how much information to give, and being emotional. Brittany, yeah, I might cry and I'm worried it'll scare them. Yeah, all really good examples. Some of the other things that have come up just in research, some parents worry that talking about it will start making it feel more real. And they're worried about giving up that control, the control over parenting of their children. They're worried about missing out on life with their kids, and this is all making it very real. They're worried about saying the wrong thing and making it worse, or scaring their kids, making it worse. And a lot of parents worry about trying to preserve special occasions and not wanting to ruin a day or ruin the time that they have, and to help try and maintain some sense of normalcy in the household. So those are some of the biggest things that come up, and they can create barriers for initiating the conversation. But when we think about why we're having the conversation and what is, I wrote it down, and what's most useful for kids, research actually shows, so when parents are feeling like they're not ready to engage or they're not wanting to proceed with this very difficult conversation, it might be helpful for them to know what research shows or what we know about kids. And there are some papers done that show that open communication might actually be protective against anxiety for the kids. We also know that kids oftentimes want to be told. So this is a study done in 2015 in bereaved adolescents, and they overwhelmingly shared that they should have been told when their parent, this was a case where they're asking specifically about if they wanted to be told about imminent death. And in these cases, overwhelmingly the kids said, yes, we think we had the right to know. But when time was very short, about 40% of kids did not know that death was imminent in their parents, and they felt that they had the right to know that. So there's obviously a gap between parents' fears and parents' worries about initiating this conversation and the kids' desire to have the information and be able to communicate honestly with their family. And what's interesting is that oftentimes parents aren't being given that guidance. So this is a study done in 2013, and they found that the healthy parents, it says health parents, the healthy parents after bereavement, that they expressed that they really desired guidance from their healthcare professionals about how to have this conversation with the kids. And their experience, at least in this study, was that it was very rarely offered. And so I think there's a big opportunity for us to intervene in a time that is very stressful. I also took out the slide, but there was a study done where they looked at patients with advanced cancer who were parents, and patients with advanced cancer who are not parents. And they found that the parents had more anxiety, had more more aggressive treatments towards the end, and were judged overall to have a poor quality of life in their last week. And so there is a big opportunity for us to intervene in these patients with very unique stressors. Okay. Just a little bit more about the benefits of disclosure. I think that when you are talking to a family and the parents are saying that they're afraid and expressing those fears, one thing that can often alleviate those concerns is just acknowledging that oftentimes kids already know, they know that something is going on, and that's across most developmental phases. They're noticing distress, they're noticing changes in routine, they're noticing changes in the patient's abilities and maybe their appearance. Or even sometimes they're overhearing conversations that you're having, that the parents are having, and they may not have the proper context to put that in. So what that can do is create a lot of anxiety and worry, because the children are hearing things and they're worried that it's actually, sometimes they catastrophize and worry that it's worse than it actually is. They may be having some anxieties that it's about them and their health or other things. So they're already knowing that something is going on, but they're not being given the guidance or the space to express their concerns. The other reason why it's helpful to have these conversations early is that kids will find out eventually what's going on. And especially in older kids, they may feel a sense of mistrust or anger or confusion that they weren't told sooner. And further, that might create some messaging about their importance or their perceived importance in the family structure. I wasn't important enough to know this information sooner, that sort of thing. And then perhaps most importantly, when parents open this conversation early, they are helping to influence their child's experience with illness coping and with coping with death. So you're creating messaging that it's okay to talk about these serious issues, and it's okay to show emotions with your family. So starting the conversation early will help guide them in what they're able to communicate with their family. Okay. So I'll provide a very general framework for how to initiate these conversations with kids. And I think the most important thing that we can offer, so some parents will really want to have a lot of detail and will want to know a step-by-step, or might even want to role play and think about language to use for their kids. And some parents might just want to wing it, and both ways are okay, obviously. But I think the most important thing that we can do is just encourage them to start the conversation and let them know that it is okay to not do it perfectly and to not have the perfect words to make their kids feel better. So we'll get into very generally how to get started if parents are wanting a little bit more detail. Okay, so the kind of step-by-step. Is this working? Okay, the first step is preparation. So parents should be thinking about, who should be there. Should it just be the parent? Should it be the parent and also another trusted adult like an auntie or a clergy person? So who is the community that should be there for the conversation? And they should also be thinking about timing. So when is the best time to initiate these conversations? When counseling around timing, it's important to make sure that they're trying to pick a time that feels right, but they're not waiting for the perfect time, because the perfect time may never come. Also, to give the child some sense of agency and some sense of control in the situation. It's great, just like we do, to ask for permission, but to give options that make sense. So, hey, I really want to talk to you about what's been going on. Can we talk today, or should we talk tomorrow after school? So giving them options that they can choose from, to have them be active participants and to give them some control. Let's see. My gosh. Something is going off my slides. Okay. Just like what we do when we are starting our conversation, it makes sense to gauge their understanding. So parents especially, they may worry about just the first words, how to actually start. And one way to ease into the conversation, just like we do, is to gauge understanding. So, hey, you may have noticed that I've been going to the doctor a lot and I haven't been feeling well. So what do you think's been going on? I didn't know I put transitions in my slides. Gosh, okay. I borrowed some kind of vital talkisms because I don't know if you're sensing a theme, but this sure feels like a palliative care conversation. And it really is. We're coaching our families to do these serious conversations. And a lot of the techniques that we use with our patients make sense for our patients to use with their children when they're having these tough conversations. So providing a headline for their children, and the most important things when they are sharing whatever the thing is, whether it's being worried about a new diagnosis or imminent death or the death of a family member, the information should be succinct, it should be honest, and it should be concrete. And we'll talk more about that in a little bit, but providing a headline that is succinct, honest, and concrete. Oh my gosh, okay. Let their questions guide the conversation. So after a headline is provided, some kids, that might be enough information for them, because as you know, even in adults, there's only so much information that our adult brains are able to process during these serious conversations. And that's even more true for developing brains. So giving them just a snippet, and if they're ready for more information, they'll ask questions. Letting parents know when we're guiding them through this, that it's okay to say when they don't know, and that this is a good opportunity for them to use like explore statements the same way that we would. The reason for this, particularly in kids, is when they hear something very serious, they'll carry a lot of anxieties and worries that they may not be able to name, or they may not even know that they're going through. And so asking some explore questions will sometimes unmask some underlying anxieties that they weren't able to articulate. There's also something really helpful that we can do at this stage when we are guiding our parents, and that is to let them know that every question is okay. There are no bad questions that kids will ask at this stage, because depending on the developmental stage, some of the questions that kids ask can seem really inappropriate to adult brains. So for example, we had a patient recently who found out that his sister was dying, and he was about, I think, 7 or 8. And his first question was, does that mean I can have her Christmas presents? And of course, that sounds really jarring and upsetting for the adult. And the mom was worried that, he needed counseling, et cetera. But providing reassurance that that's a normal question for this developmental stage can help alleviate a lot of worries for parents who are having this conversation. Yeah. Okay. Finally, the next piece is addressing emotions and acknowledging your own. Kids across the developmental spectrum are going to have a huge range of emotions and behaviors that we'll talk about in more detail, but making sure parents know that all of those reactions are normal, and that it's okay to address them and say, I can see that this is really sad for you. It's sad for me too. And a lot of parents, just like Brittany had pointed out in the chat, feel like they have to kind of keep a brave face or stay strong for their kids. But actually, parents should feel free to cry in front of their kids, acknowledge their own emotions, because that's creating messaging that it's okay to talk about and it's okay to feel badly about this. Okay. Another issue that comes up across the developmental spectrum when we're having this conversation is that all kids are going to worry about how their parents' diagnosis is going to affect them and their care. And so no matter the age, we should also always be volunteering that they're going to be cared for no matter what. And we should be providing really explicit and concrete examples of how kids are going to be cared for. So, you know, I'm going to be going to the doctor a lot, but your neighbor or neighbor is going to be picking you up and taking you to soccer practice. It may seem trivial to adults when they're going through something very serious, but these small details, these logistic things are major worries for kids when they're having these conversations. Okay, and the last piece is just to give them time. There was one analogy that was in an NPR article that I really liked, which is about how kids eat apples. So in adults, if you have an apple, you eat the apple and then you throw away the core. But in kids, they pick up the apple and they take a little nibble and then they put it down, and then they return to the apple much later and they take another little nibble and they put it down. And it's kind of like the same thing where they're not able to take in a ton of information at once. And so they should be given snippets over a long period of time. The other thing is that parents oftentimes worry that their kid isn't really getting it, that they don't seem like they understand. And that sometimes is because they're the kid, when they receive the information, their emotional reaction may not be what we expect or what we would expect in adults. And so they may see a kid that seems maybe unaffected and they think, oh, they don't understand. But that might just be how that kid is processing based on their developmental age. And then the other piece of this is, you know, they may not get it. They may not be developmentally able to get the, you know, the concept or whatever it is that they're talking about. And that's okay. So if they're not developmentally able to get it, that's part of why these conversations aren't had over days, but are truly had over years. So as the child grows and develops more cognitive abilities, they'll return to this conversation and understand it in a more complex way, in a more mature way as time goes on. And so that's why opening a conversation and revisiting it as many times as they need over years, so that their understanding of the situation grows as their development grows. So those are the biggest things. I'll pause really quickly. I'm going to get into a discussion about specific developmental ages and how they understand serious illness and death. But I just wanted to pause, see if anybody had any questions about that general framework or any comments before I move on.
Stephanie, I had a question.
Sure.
Oh, sorry, Wayne, I didn't see your hand up. I was wondering, I don't know if you'll get to it later in your talk, but if you saw anything in terms of if the kids are very different ages, like, do you talk to them together? Do you talk to them separately? I don't know if that'll come up later, but that your framework raised that question in my mind.
Yeah, I think that's a good question. And it depends on the family. I think it is appropriate if you have a much older kid who is able to understand things really well to maybe talk to them first and then talk to them together with the younger kid. There's no right or wrong way, but I think if you have kids who are very different, that it makes sense to have conversations with them each individually. But I would say not a wrong way and a right way. Anybody else have thoughts about that or strong opinions about that in the crowd?
Well, Stephanie, I was just going to reflect in listening to your talk so far. You know, talking to adults sometimes isn't so terribly different. You know, it's in American society, it's pretty easy to survive well into adulthood, having never seen a person die or a dead person, except on TV, which is, of course, not the real thing. And often, you know, adults have similar questions and might have odd questions that sometimes come out with the what do you think is happening, you know, lead in that we often use. But what I'm just pondering about is, maybe some of the takeaways from your talk this morning pertain to adults as well, and we should be sensitive to it. And in talking to children, I've encountered children fairly young who actually have fairly extensive experience with death. Some refugee kids here at Harborview and others have seen a lot of death and not necessarily that traumatized by it. So it's so variable. It's hard to, I think that's what scares all of us is what one might encounter is so myriad that it's kind of hard to know.
Agreed. Every kid is going to be different and their understanding is going to be so different. But I agree with you, Wayne. It feels like going through this framework, it feels a lot like conversations that we have with adults all the time. But just small things can be changed to make it more palatable for kids. And what I would say about kids who have different experiences with death, I think like all things, remembering that the parent that you're working with, the patient that you're working with is ultimately the expert in their kid and can help, so it should be a back and forth conversation about, how developmentally or emotionally mature is that specific kid and how can we tailor the language to fit an individual kid. But you're right, ultimately, that it's hard to predict how they're going to tolerate it or how they're going to understand it. And so no matter how they react, making sure that we are providing like safety and support, whether they understand or don't understand. So.
Well, that would argue to Nora's queries that, we probably err towards having the parents present since they know more about the child than we might know about their experiences.
Oh yeah, I completely agree. I should have been a little more clear that I think that these conversations are best had by the parents. And I think our role is mostly guiding them, or mostly coaching how to have the conversation and helping them have a space to talk about how to have the conversation, just to provide them space and to provide them with some brainstorming. So I think our role is much more suited to coaching the parent than it is to having the conversation with the child. But sometimes we're in that situation where we're the ones having the conversation with the child. So it's good to be prepared. Thanks for your comments. Okay, so we'll talk a little bit about ages and stages and how some different developmental groups will think about death and serious illness. I do want to acknowledge, kind of like Wayne said, that I'm talking about buckets, these discrete buckets, but really it's more like this. There's really a spectrum and there's tons of overlap, and kids who are maybe advanced in one way might not be in other ways. And so there's no real one size fits all approach, but we use these kind of artificial buckets to make it a little easier to talk about. So I just wanted to acknowledge that. When thinking about a child's understanding of death, kids need 4 developmental abilities, or for the ability to understand 4 concepts, and they are finality, so or non-functionality, so the idea that the body stops working when it dies, irreversibility, so the idea that death is permanent, inevitability, so death is universal, and finally causality, so what is the cause of death. And kids develop these skills or the ability to understand these concepts as they develop, and their ability to understand them will influence how they see death and how they respond to it. So let's first talk about babies. So babies, their major developmental task is forming attachments, developing self-regulation, and developing trust both in their caregiver and in their environment. And I think that my bias before this was to think that, you don't have to worry about the babies. They don't understand what's going on. But truly, I wasn't giving them enough credit. Babies really do pick up on quite a lot. They can feel strongly the absence of the caregivers. They are very sensitive to changes in their routine, and they are affected by distress and grief of the surviving adult or whoever is their caregiver. So they can sense the tension and the, grimacing of the faces, things like that. So they can pick up on distress and anxiety in their caregivers. Some responses that you might see. So infants and toddlers will respond with their behaviors. So you'll see a lot of irritability, you might see crying, and you might see changes in how much they are eating. So being mindful of that is important. And you may also see, because they don't have a lot of the they don't have the understanding yet, that you might see them continue to search for the deceased person after they're gone. So what can parents do to help support infants and toddlers? So the big theme for this age group is maintaining routines as much as possible and maintaining consistency. So if there is a death approaching, one strategy they can think about is finding a caregiver who is outside of the parent dyad, and having that person be a through line, because oftentimes the well parent, if there is one, is going to be very preoccupied leading up to the death and after the death. So having an extra person, maybe a grandparent or an aunt or something, who can be present leading up to the death and can still be there as a source of stability through the death and after, just to provide routine if a family has that at their disposal. So that's one way. And then another, just thinking about practical things like using the same bottles, using the same blankets, using the same cribs. So things that are familiar to them to help them with their sense of security and attachment. Extra physical attention, just TLC, and being mindful of their physical health. Are they eating? Are they peeing and pooping? Are they losing weight? Sometimes kids might lose weight, so it's something important to think about. And in small infants who are still bottle feeding or who are breastfeeding, it's important to at least think about what their feeding plan is going to be as the parent gets sicker. Preschool age, so 3 to 5 or 6. These kids are extremely present focused, and they're very, very literal. They have egocentrism, not in a bad way, but they only see the world as it pertains to them. And they also possess magical thinking. So magical thinking is this fantastic way of thinking where kids believe that they can influence things with their minds. They have really idiosyncratic kind of associations and connections that they draw. And that plays into how they understand the dying process. They do not have an understanding of irreversibility. They do not understand causality. And they're also very distressed by changes in routine. So how that might show itself when there is somebody seriously ill or a death in the family. One, because of their egocentrism and magical thinking, and because they don't understand causality, oftentimes these kids might attribute the situation to their own behavior. So they might think that they did something bad and that caused the bad thing to happen. So like a common example is like if a kid threw a tantrum and said, I want mommy to go away, and now mommy is sick, they'll worry that they're the reason that mommy is sick. And they may also, because they don't understand the issue of permanence, they might think that they can come up with a way to solve the issue. So bringing their parent back from the dead. So those are things that you'll see often in these preschoolers. Things that are extremely common, regression is super common across the spectrum. Bad dreams, also searching for the deceased. These kids will be irritable, they'll have some separation anxiety, and you may also see changes in their habits. These kids will have really repetitive questions. Anybody who has a preschooler knows that. And so they'll ask the same things over and over again, and parents will be responding to these questions over and over again, and that's normal. It's also a time that you might see some thematic play. So issues of illness or of death might come up in play or in art, which creates an opportunity to explore those feelings with the kids. And another thing to normalize for parents is that their reactions may be brief, but very intense. So they might have a period of time where they seem somewhat unaffected, and then they'll have a huge emotional reaction, and then they'll go back to playing Legos or whatever the thing is. And so parents might sometimes worry that if there's a period of time where the child seems unaffected, that they're not really getting it again. But keep in mind that there's this kind of cyclical nature to it, they'll have these bursts of emotional reactions, and that's normal. I think I saw somebody raising their hand.
Yeah, with this group of kids who display regressive behaviors, such as sucking on the thumbs or bedwetting or
Yeah, absolutely.
that.
You'll see regression in this age group, and you can see it much later as well. But yeah, thumb sucking if they've already grown out of it, bedwetting are the common ones, or wanting to sleep with parents if they've grown out of that, or sleeping with their sibling if they've grown out of that, needing their old loveys or their old blankets. All those things are really common. And what we can do to support parents is specifically about regression. Parents really worry about this behavior in their kids, and we can reassure them that it's a normal way to self-soothe, and it's also temporary. So they'll grow out of it, and trying to alleviate parents' concerns that they don't need to retrain their kid out of whatever behavior they've readopted. So if the child is being soothed by sucking on their thumbs again, then that's okay. Just let them do it. They'll grow out of it. Other things that we can do to support kids of this age, one is being concrete and avoiding euphemisms. I think everybody in this crowd knows to say death and dying and to avoid euphemisms. And I think that it's most important in this age group because they are so concrete and so literal. So as an example, if you were to say something like, mom is going to sleep forever, you might accidentally create anxiety around sleep or fear of sleep. Or if you were to say, cancer is a lump or a bump that gets bigger, then if the kid bumps his head in the playground, you might worry about what that bump is. So being really intentional about the words that we're choosing and knowing that they're going to interpret it very literally. Other ways to support, revisiting the topic again, over and over and over again. And then volunteering reassurance that they are not to blame. Again, Lauren says also using words like chemo and not medicine. That's a good point. In my language examples, actually, I use the word medicine, Lauren, but that's a really good point that I thank you for pointing that out. So medicine, they might need medicine for their own illnesses later on, but they might worry that it's the same medicine that mom got for her cancer. So really good point. So volunteering that they're not to blame. So again, they might not have the words for guilt or be able to explain that that's what they're worried about. So always saying that, the doctor said that it's nobody's fault that mom has cancer. That's really important. And this is a good opportunity to use your resources. So storybooks, kids movies, anything where there is some motif of death that can be used. Paula sent me an article a while ago about Pixar movies that have death as a motif and how that can be used to talk to kids about death. It's also a good opportunity if there's anybody in the past, if there was, or like a pet who passed away or who died, that you can use that you can bring up as an explanation. And then I'll say this for every age group, but providing consistency and some regular routine is another important piece of supporting these kids. You guys can probably hear my cats. I'm sorry, they're going nuts. Okay, so the next age group that we'll talk about is this 6 to 12 kind of school age group. So the developmental things going on with these kids, they're gaining increased independence, they're gaining more of a sense of identity, and they are developing more peer relationships. They're learning more about the human body, and so they can understand finality mostly, so they can understand that the body stops working when it dies, but they don't always have a firm grasp on inevitability and causality, especially in the younger part of this age group. And they may struggle with issues of fairness and issues of naming emotions. So some of their responses that you'll see, just like in the previous age group, some of their questions might be a little jarring to parents. So some of these kids, they'll ask really matter-of-fact questions, and they'll also ask questions. Sometimes they'll have kind of a morbid curiosity. So some of their questions might be might come across as insensitive to parents. So just remembering and reassuring parents that, again, there are no bad questions. It's normal for them to ask these sorts of questions, even if it is uncomfortable for the parents. You might see some physical symptoms based on either changes in habits, or maybe they'll have some somatization. Some of these kids will show some uncharacteristic behavior. So in a kid that's normally gregarious, they might become withdrawn or indifferent. You might notice irritability or even issues in school like bullying, that sort of thing. So reassuring family that, that these things are temporary and that it's normal. Regression you can see also in this age group. So kids might wet the bed, kids might suck their thumbs again, they might have more childlike language or behavior. That's really common. And these kids will worry about fear of isolation. They worry a lot about being different from their peers. And kids this age will worry about their own health. So they'll worry about the health of themselves, they'll worry about other families' health. So it's important to make sure that they know that, you know, just because mom has cancer, nobody can get cancer from being around me, that sort of thing. And these kids also worry about logistics. Who's going to bring me to soccer practice? Who's going to make my lunch? That sort of thing. Kids this age will also experience guilt. In the younger age sets, some kids might have the issue of causality, worrying that they somehow caused it. But in the older age set, you might see guilt more around behavior, you know, like I yelled at mom and now I feel bad for acting that way because she's sick, that sort of thing. So making sure that any feelings of guilt are being addressed. Ways that we can support this age group, or that we can encourage parents to support this age group. One, school is such an important part of their lives right now. So trying to think of the school as one term I liked was like an island of normalcy. So as much as it's chaotic at home, trying to make that environment feel as normal as possible. And if it's appropriate, maybe involving people at the school, if there's a trusted adult, a teacher. One thing to note, because this family or this age group is very concerned about peer relationships, that they may not want people to know. So making sure that they are okay with sharing information with the school. Maintaining routines and responsibilities. So if there are certain chores, if there are homework, if there are certain boundaries and rules, making sure that those things are preserved throughout the process. While keeping in mind that, you know, they might need extra help, they might have some difficulty concentrating, but expectations that were set before the parent became sick should be withheld throughout to maintain that sense of routine. Being really explicit about what they can expect. So again, making sure that they know who's going to take care of them, how they're going to get to soccer practice, all of those things are really important. Addressing anxiety about their own health, addressing the guilt that we talked about, and somatic complaints. And again, keeping things really honest and consistent, because questions are going to come up again and again, just like in the past age group. So making sure that there's consistency in answering so that they are receiving consistent messaging from everybody. Teens. So when we get to the teen age group, these kids have understanding on par with adults, but they may not have the same emotional maturity to process the information that they are now able to understand. So they're thinking much more abstractly. They're developing some separation from their family unit. They have an enhanced sense of self-identity, and they're thinking more about abstract terms like justice, like suffering, like making meaning out of everything that's going on. Their responses to serious illness, kids in this age are really going to feel strongly the personal effects of loss. So they're going to think a lot about how a death in the family or a sickness in the family affects their ability to lead their typical, their typical lives. They may also worry about changing roles. So it's really common for teenagers to be given a little bit more to do to help the family unit during a time of illness, running errands, helping with cooking, whatever it might be. So there might be a lot of worry around taking on too much and having a role that's becoming too much like an adult role in the family structure. You may see existential crises, you may see guilt, but unlike guilt in the younger sets, the guilt here is a little bit more abstract. There might be some survivor's guilt about being the healthy person, that sort of thing. Again, worry about difference from peers. And some of the coping mechanisms are going to really vary in this age group, but some kids may cope with things like risky behavior, withdrawal, anger, and you'll see somatization, difficulty sleeping, difficulty with concentrating in this group. Support for this age group, you want to provide them with all the information that they want. And again, the parents are the experts for this age group, just like all the other age groups, about what they think their children are going to be able to understand and take in. These kids, because they're savvy, they'll probably be doing some research on the internet. And so it's okay to create a space to talk about what they're reading online and saying how much it applies to you or not. But I think it provides them with the sense of agency to feel like they're helping by doing that research. So spending time going through that stuff together. Get their opinion about what should be shared with the community. So because these kids worry so much about difference from peers, they may not want information on social media. They may not want their friends and families to know. So making sure that that parents are engaging this age group about what's being shared and how and when, just to make sure that they have agency in that conversation. Helping them find ways to express feelings, art, music, counseling, that sort of thing. Just however makes sense based on what family knows about their kid. One way that we can reassure parents is that a lot of kids in this age group, they may not want to talk to their parents about what's going on. They may choose to talk with a friend or some other trusted adult. And that can sometimes be hurtful for the parent who wants to be there to support their child. So offering reassurance that that's normal, and the most important thing is that they're having an outlet to talk. And I already mentioned this, but being mindful of new roles and increased expectations. So it's really easy to pile onto a teen in the household for help, but keeping in mind that they're still a child and should still have opportunities to, or they shouldn't be too overloaded with that sort of thing. So just being mindful of it. Kids do like to help. They do want a role in all of this and to offer help to the family, but just being mindful of how much help is being asked. This is just a summary of, this is just from up to date of the different developmental phases and their understanding. It really bothers me that these lines aren't lining up, but let's not talk about it. And then I just wanted to pull out the things that were most important that, or the things that went through all age groups, some of the through lines. So just as a reminder, providing reassurance, no matter the age group, that the child's needs will be met, that they'll be continued to be supported, maintaining as much consistency and routine as possible, addressing concerns about their health or any anxieties they have about their own, like catching cancer, that sort of thing, reassurance that they are not to blame and they have no reason to feel guilty, and then for all ages being honest and concrete. And we didn't really talk about this yet, but in these conversations that we're having with our patients, when they're thinking about how to talk to their kids, it's a really good opportunity to start talking about legacy and remembrance. So no matter the age group, helping families think about how they want to be remembered and what strategies they'll use. Can you see that? I wanted to do a video, but I think I'm running out of time. Thanks to Susan Merrill for pointing out this video. This is a Sesame Street video where Big Bird learns about the death of his friend, Mr. Hooper. And I'll put the link in the parking lot because I don't think I have time to show it. But it just shows Big Bird learning about his friend's death and how the adults in his community manage it and how they talk to him about it. And when I saw it first a long time ago, I thought it was really sweet. And after doing this research and watching it again, I thought, they really know what they're doing. So if you have time to watch it, again, we'll link it. But some things that they did really well is that they are using concrete language, developmentally appropriate language. Remember, Big Bird is canonically 6. They're succinct. They revisit the topic. They address his worries about how he's going to be cared for, and they acknowledge emotion. So I want to show it, but I don't think I have time, so I'll keep going. But if you have time to watch it, I think it's a really good example from the experts on how to talk to kids. I want to provide.
And last but not least, ta-da! Oh,
So
beautiful. Yeah, it's really. Can I see that?
Oh my goodness.
Thanks, Stephanie. That was terrific. And I will definitely watch that video. And it occurs to me that there's quite a bit of wisdom on the call here this morning. And it'd be great to hear for people who have a depth of experience, maybe Carol, Kamat, or Leah, might make comments about words of wisdom they've gleaned over time.
Stephanie, if that's okay, I have found something that has worked really well when I'm meeting with the children and the parents. And it's just a little trick of bringing pipe cleaners along. And then the kids and the adults have something to do with their hands, and eye contact is different, and creativity flows, and the kids aren't being talked to, but we are doing this where we have something to do together. When you mentioned music and art and such, pipe cleaners are really cheap and easy to carry around.
I love that idea. Thanks for that. Sorry for that technical glitch. That was a little stressful. Can you see my slide again? I wanted to provide a couple of examples of language, not because I think that these language examples are perfect by any means, but I think parents really worry about finding the exact right words or finding the magic words that will make this conversation go smoothly. And I think it's helpful just to see how simple the language actually is. And for some parents, it can help assuage a lot of concerns that it's really not finding the magic words, it's just finding words that make sense, and that it doesn't have to be perfect. So I'll just go through, I just wanted to go through one or two, and then I wanted to open for questions and other comments. So a couple of examples. So for younger kids, for a new diagnosis, saying something like, I'm sick with something called cancer. I'm going to be visiting the doctor a lot and taking medicines to get better. Some days, Mrs. Smith will bring you to preschool instead of me. So being really direct, using the word cancer, and then addressing what they'll be concerned about, which is how are my needs going to be met? I think I have a lot of time. When thinking about transitions in care and thinking about introducing death, it's really important to talk about death in a physiologic way. So talking about death is what happens when the body stops working. So this is just an example of how to introduce this idea of being worried about impending death or transitioning to that mindset. So you know that I've been taking medicines from the doctors, but I do like the idea of changing that to chemotherapy from the doctors to try and get rid of my cancer. The doctors told me that the treatments aren't working anymore and my cancer is getting worse. As it gets worse, my body can't work like it's supposed to, and it will eventually stop working. When my body stops working, I will die. Sometimes people die from cancer, even when we're getting treatment, and it looks like it's going to happen to me. I'm feeling really sad that this is happening. Again, I don't think that this is perfect language, but I think that it just helps show how direct you can be and how to explain death in the right context for a younger kid. And I don't have time to go through all these examples, so maybe I'll just pause there. They'll all be in the parking lot though, if folks want to look at it. Just one more point I wanted to mention about preparing for death, and then I will be done. A lot of people ask if kids should be in the room when their parent is dying. And it's a really personal decision, and it's going to be different for every family and for different kids. And I think some people say that kids as young as 6 and 7 can make this decision on their own. But I think all kids should be given the option to be at the bedside. And with that, they should be given all the information that they need. So they should know what they're going to see and hear. they should know if this is going to be the last time they might see their parent. And they should be told that there's not a right way and a wrong way, that it's okay if they choose to see their parent and it's okay if they don't. There is one paper that I read that said that a lot of kids found that forced exposure to the dying parent was a source of trauma, and seeing really physical evidence of their sick parents was a source of trauma. So being really mindful about that. And then whatever they decide should be respected. And the same goes for funerals. So having an adult assigned to the kid if they decide to see their parent, but if they get overloaded and need an exit to go somewhere safe, having an adult that they trust to be their kind of guardian for that. Having an activity ready. This is a good opportunity to work on legacy pieces. So that's the only thing I wanted to say about preparing for death, giving them options, but giving them the information that they need and respecting the option that they choose, I think is really important. I've run out of time, so I think I'm going to leave it there. I have some more language, but I'll throw it all in the chat. I was going to mention single parents are facing unique challenges, especially regarding remembrance. So if you have single parents in your clinic, talking to them early about identifying caregivers, working on legacy early in the process. So my takeaways from putting this together was encouraging parents to start the conversation is the most important thing we can do, offering them reassurance about the responses their kids are going to have, being honest and concrete, and keeping the lines of communication on it open for years. These are my citations. Thank you. That's all. And a special thank you to Paula and Melanie, who provided me with a ton of resources and helped me put everything together. So that's all I have. Thank you so much for listening. And then I'm open for any questions or comments or other ideas that folks had as they were listening.
Hey, Stephanie, this is Gina. Thank you so much for this talk. So since I'm in the outpatient setting, this comes up like really commonly, especially parents living with a chronically serious terminal illness. So like in two settings that I typically find this the most with young parents is in the Heart Institute, people that have VADs or getting, evaluated for transplant. And then in the ALS clinic, so there's a lot of like young parents who are diagnosed early with early onset ALS. So this comes up a lot. And so I feel like a lot of the times that I see them, since it's such a chronic terminal, like the different stages of illness, is that the conversation comes up again. So like they see the changes in their parent over time. And then it just, they're like, oh, how do we have the conversation, of the changes that they're seeing? So it's like revisiting it again, which is kind of what I've experienced with that part. And then one of the resources that I found really helpful, since my patients come from all over the state of Washington. Unfortunately, it sounds like, there's only safe crossings in King County and then the Mary Bridges in Pierce County, but they've been offering virtual visits with parents and or children, specifically through the Mary Bridges, since there aren't that many resources, in Eastern Washington that I know of, or like, Skagit County or anything like that. So I found that really helpful, that there is that resource. And this came up during COVID too. So, offering that virtual platform. So just wanted to kind of throw that out there as a resource that they're offering. And it doesn't sound like that they're going to take it away. So I'm hoping that they don't, because I don't know what else I would be able to offer outside of like, the resources and booklets and handouts and stuff. So.
Yeah. And Argo also mentioned in the chat that the Journey program through Children's, they offer support for kids that I think that can be anywhere statewide, but I'm not sure. Camp Aaron, that's a great one. Yeah. Okay, any other thoughts, any other suggestions or questions?
Well, we're at time, Stephanie. Thanks so much for your talk. This is great. I'm sure you'd be happy to answer queries if people want to email you
Absolutely.
later.
Yeah. All right. Thanks, everybody.
Thanks, everybody.
All right. Bye.
Have a good day.